My pleasure to go over kind of a shift in paradigm. We're talking about treating PAS and CSC all the time, but really, I think we should be talking about prevention, and I hope to focus on that in my two talks today. I have nothing to declare. I do some editing work and research. And again, I want to focus today on prevention. Prevention is so much better than treatment or cure. And for Akria in particular, for such a terrible consequence, I think we should talk more about preventing. I will talk about prevention of a C-section in general. So is that how we can prevent an Akria? If we decrease C-section, is that viable? I will try to make the point actually that I don't think C-section is going to decrease at all. In fact, probably going the other way. And then I think the true answer is that we need to find ways to do a C-section in better ways to prevent a cesarean scare, ectopic, or placenta Akria. And I will cover some of that in the next lecture as well. So the story is that I have 4 kids. The first 2, they were trial of labor. The second one was a trial of labor after C-section. Both arrests in the second stage for 5 hours plus. And despite their mom's wish to deliver vaginally, my wish to deliver vaginally, no go to C-section. And then I'm remarried. I have 2 young ones. And my wife wanted to have cesarean delivery on maternal request, and the point here is that all 4 are doing well, and C-section was not the end of the world. In fact, the third kid is called Cesare. I think cesarean is in our blood, and again, I'll go over data and try to make you think differently because we have changed. We used to not brush our teeth, and now we have plenty of randomized trials and Cochrane reviews saying that we should brush our teeth. Hopefully you have flossed this morning like I did, because again, there's lots of information that flossing works. So we should lead an evidence-based life, both at home and at work, and be open to change when new data comes in. So the first part is preventing it of C-section. There's lots of data. This is probably the most quoted effort by ACOG and SMFM, certainly big one here in the US. Obviously, if you decrease labor arrest, breech, and non-reaching field testing, you can make a big dent in C-section. And that's what experts have done, and we have helped here. If you are, wait during labor and give it a longer time, if you don't do a C-section, before active labor or 6 centimeters, if you don't call a failed induction too early, and you wait for adequate contractions, also in the second stage. We published this, which is one of my most quoted articles, even before ACOG and SMFM came up with this. And in the second stage, be patient. Obviously, if you wait 4 hours, for example, with an epidural and no lip, you're going to have less C-sections than if you call a C-section at 2 or 3 hours in the second stage. So many efforts, again, longer second stage, considering operative delivery, which would save a C-section, rotating the head if it's malpositioned in the second stage. We published a meta-analysis recently saying that that's effective and safe. Amnioinfusion, scalp stimulation, and now actually with the ARRIVE trial, if you induce at 39 weeks, you can also decrease the C-section rate, doing a version for breech, doing an induction for fetal microsomia, twin gestation offering a vaginal delivery if the first baby's vertex. These are all things that would decrease the C-section rate. In fact, using midwives instead of us physicians, birth centers, and other issues related to social and legal aspects can decrease the C-section rate. I will cover labor and delivery, etc. But the point is that if we're looking at quality, at the end, we want a good baby and a good mom. And would you having a C-section rate of 20% versus me having a C-section rate of 30% really make you a better obstetrician than me. At the end, I think the best indicator should be the mom is safe and the baby is safe, and the mom in future deliveries, is not going to have a placenta accreta. I'm going to make the case in the next 10 minutes that actually the C-section rate, despite all these efforts, will not decrease. The C-section rate is now 32% here in the US. It's much higher in some Southern European, South American countries, China, etc. And because of the data I'll present to you, I don't think it's going to decrease. And this data was just published in Age-OG-MFM, the Pink Journal, by one of my collaborators, Wiki Adewale, and we'll talk about some preferences, the fact that birth weights are getting bigger and pelvises are not getting smaller. And all of this, it's either in the Pink Journal or in the Gray Journal. So if you have a 36-year-old with a first baby at 10 weeks, what do you tell her? What's the best delivery? And again, Vicky did this meta-analysis, which has been published now in the Pink Journal in 2023, just a month or two ago, comparing a planned C-section versus a planned vaginal delivery, kind of, answering the age-old questions. Can we really get rid of C-sections? Is vaginal delivery safer? And doing a meta-analysis of randomized trials represents the best data available. So that's what we did. Then we looked at the ultimate outcome of perinatal mortality, looked at lots of other outcomes, maternal and baby outcomes, and we did a large search, over 5,000 records reviewed, and eventually came down to actually there are 15 randomized studies looking at planned vaginal delivery versus planned C-section, with over 6,600 patients randomized. So this is not small data, and the data actually comes from South America, North America, Europe, Asia, Africa, really everything. And it is a little bit heterogeneous. Trials on breech, twin, eclampsia, etc. So not all low-risk patients, but patients that, because of whatever issues, as you can see in the slides, were offered being randomized to a planned vaginal delivery or a planned C-section. In general, these were younger women, many nullippers without a prior C-section, and the one randomized to have a C-section, most of them had a C-section, and the one randomized to have a vaginal delivery, 40% had a C-section, meaning even if you try to deliver vaginally, sometimes you can't. And briefly, the results, perinatal death was the same in each group. The first data is going to be C-section. The second is going to be vaginal delivery. So, for example, here is C-section, 8% general anesthesia versus 7.6 for vaginal delivery, slight increase in general anesthesia. And some of these are older studies, so that's why probably general anesthesia. In green are the data that favor C-section. C-section here, it's better for chorioamnionitis. Obviously, if you don't go into labor, if you have a planned C-section, you're not going to have choreo, usually very low risk, high risk for vaginal delivery. Wound infection happens if you have a C-section, so higher if you always have a planned C-section. This is breastfeeding, which is actually at 6 months and 2 years was the same, but was slightly lower for C-section. Urinary incontinence was actually 29% less with a planned C-section and 23% less at 1 to 2 years. So a significant decrease in urinary incontinence with a planned C-section. Painful perineum at 2 years was less. And then if you look at perinatal outcomes, they were all better for the baby. So planned C-section is safer for the baby, better pHs, less birth trauma, less tube feeds, and less hypotonia. So this data again published, you can see it in Age-OG-MFM. And the summary is that for the maternal side, most things favor C-section, but some favor vaginal delivery. And for the baby side, actually, if you look at short-term baby's outcome, they favor the C-section side. Unfortunately, this data, there's not much. We'll talk about risk of is cesarean scar, ectopic, and placenta accreta spectrum disorders. The data I just showed you is for just, looking at one C-section versus one vaginal delivery, either or. And clearly, you can make the case that C-section, based on that data, is not going to decrease. And also based on this other data, also published in the Pink Journal by our colleague Tanvi Rana, who was our medical student at Jefferson. Few patients around the world want a cesarean delivery on maternal request. But when you ask obstetricians, were there in labor and delivery taking care of women, what they would do for themselves if they had a nulliparous singleton term vertex, low risk pregnancy in their first pregnancy, 14% they say that will favor them having a cesarean delivery on maternal request. And actually, the ones who had babies, 25%, 1 in 4. I want you to remember that number. 1 in 4 obstetricians from complete survey of the literature has had a cesarean delivery on maternal request on their first pregnancy, nulliparous singleton term vertex low risk pregnancy. So we talk about 1 in more vaginal deliveries, but 1 in 4 of us has a quote unquote elective planned C-section. And in fact, 2 out of 3 of us will recommend our daughter to have the same. While midwives don't, and urogynecologists obviously are all for C-section. So another point I just made for the fact that C-section I don't think is going to decrease, and certainly we're not electing vaginal deliveries always for ourselves as obstetricians, and birth weights are going up. These are US data, again, published also in the Pink Journal. As you can see, there's an increase significant over the last 30 years or so in US birth weights, probably due to increases in BMI and diabetes. But even in the world, and this is being published in AJOG, even around the world, birth weights are getting higher. So I just don't think that C-section is going away. The pelvises are getting smaller. It's really hard for humans to deliver, as we know. And I just think that as we look at this, again, 32% C-section rate in the US, I think that this conference is really important because I think the C-section rate is not going to go down. And if obstetricians 1 in 4 have a C-section themselves, I think that we probably bias our patients too, and we're going towards that. And our meta-analysis showed that it's not so crazy to have a planned vaginal delivery, especially if you're going to have 1 or 2 babies. And I'm actually submitted a NIH grant to compare planned C-section versus planned vaginal delivery, a term in nulliparous singleton term vertex pregnancy, so low-risk pregnancies, in patients that want to have 1 or 2 babies only. So, for example, 35 or older. We'll see if this gets approved. Canadians and Chinese are also interested, as well as South Americans. Obviously, we would have to follow this to end of reproductive life to see the risk of accreta. But in this population, 35 years old or older, that may have only a few pregnancies and less of a risk of an accreta by having, multiple C-section, this will be interesting. And certainly, we are working with pelvic floor disorders people and obstetricians and MFMs to look at next pregnancies, the risk of accreta. But again, the key here is accretas usually happen, as you know, with people that have more than 2, 3, 4 C-sections. So the point of this first lecture was, yes, you can try to prevent C-section by doing, managing labor a certain way, being more patient, longer second stages, etc., waiting longer for induction, more and more inductions. Obstetrics, after all, means obstare, standing by, waiting. And that, yes, may decrease the C-section rate. But looking at comparing planned vaginal delivery and planned C-section, looking at preferences of obstetricians, looking at the fact that birth weights are going up and pelvises are getting smaller, I predict that C-section rates, despite our best efforts, will not go down. And I look forward to more randomized trials comparing planned C-section and planned vaginal delivery and looking at the long-term outcomes, because at the end, we need the long-term, especially, cesarean scarectopic and PAS follow-up. This last slide for this talk is about what I think is most important in our discussion of preventing of cesarean scarectopic or placenta accreta spectrum disorder during the C-section, around the C-section. And I think that what we should focus on thinking of preventing an accreta. Preventing an accreta is not going to be done again by deleting C-sections. They will always be here, and I think there will be more and more. But perhaps if we do a better C-section, then that risk will go down. And in the next lecture, I'll go over in detail. We're working on a systematic review, looking at, does timing of C-section make a difference? If you do it early in labor or second stage or late in second stage, where you put that incision, vertical, horizontal, lower, higher, the type of incision, does that make a difference in terms of the risk of the next embryo implanting on that cesarean scar? What about manipulation of the uterus? What about if you scrape it? Some people scrape it with different instruments. Some people do it with a gauze. Some people put iodine. I've seen all kinds of things around the world. And what about especially closure? That's probably where most people are focusing now. What about if you close it with 1 or 2 layers? If you close it with a purse string, or if you close it with interrupted or continuous sutures? What kind of sutures may make a difference? And there begins to be some literature on that, and I thank you, some of you, for having published that, and I will review it in the next talk, so that I don't go over my time here. So the take-home message from this first talk, and trying to get you thinking, is I think that in terms of prevention of accreta in particular, which I think is the most important issue, you can look at niche, you can look at thickness, you can look at cesarean scarectopic, but really what we want to present is an accreta that ends up with needing an hysterectomy and putting the patients at risk of death. So to prevent an accreta, I think that the answer is not going to be, we're going to prevent lots more C-section. I don't think that that's going to be successful. From my read of the evidence, I think instead C-section rates will not go down and may continue to increase. They may not be the worst thing in the world for mom and babies in the short term if they're going to have 1 or 2 babies. But the key, I think, instead is going to be on technique. Is going to be, how do you do a C-section that subsequently has the lowest possible risk of cesarean scarectopic or placenta accreta spectrum and disorders. I think that that's the key, and I hope I whetted your appetite enough so that you come back this afternoon and you listen to my second lecture. Thank you very much.